Hi, good evening, everyone. This is Munir Ghasani. I am Chief of Nuclear Medicine at Mount Sinai and current President of SNMMI. It is my absolute pleasure and delight to introduce Dr. Tony Abram. He's a skilled and experienced nuclear radiologist. He's fellowship trained in PET-CT and nuclear oncology at Memorial Sloan Kettering Cancer Center. He joined Montefiore Medical Center thereafter, where he was the director of nuclear medicine residency program and an associate professor of radiology at Einstein College of Medicine. Currently, he is the chief of nuclear medicine and theranostics at NY Imaging Specialist, the imaging wing of New York Cancer and Blood Specialist. He has multiple publications in peer-reviewed journals. He has been involved in multiple imaging research trials and has been invited speaker several times to the Society of Nuclear Medicine and Molecular Imaging and RSNA. He also holds committee memberships and positions of leadership at local and national SNMMI. It is my pleasure to invite Dr. Abram to talk about software a paradigm shift for efficiency gains in molecular imaging and nuclear medicine. Thank you.
Thank you, Munir, for that kind introduction. And thanks to all the audience members who are joining us this evening out of their busy schedules so we can have this webinar and discuss efficiency gains that can be achieved with nuclear medicine imaging software. So getting right into the talk, the focus of the talk is to bring to forefront imaging platform solutions that can be leveraged to improve workflow and create ease of use for physicians, technicians, and other clinical services that use nuclear medicine products to positively impact patient care, especially as our field has become more complex in a good way. What I mean is nuclear medicine has significantly evolved over time from general nuclear medicine and a few therapies to a multifaceted practice covering a full spectrum of general nuclear medicine and PET-CT and multiple therapies. Also, we're not immune to external factors that affect nuclear medicine practice, such as reimbursements, whether it be academic or private practice, or to completely unforeseen situations like the COVID era, which has tested us to see how we adapt to them. The field of nuclear medicine is currently undergoing a significant renaissance period, whether it be new tumor-specific tracers, such as in the field of neuroendocrine and prostate cancers, or new tumor-specific therapeutics, such as lutetium-based therapies for carcinoid and prostate cancer, with several new imaging and therapeutic agents in the research pipeline. There is greater awareness of nuclear medicine and outreach carried out by several organizations, such as Society of Nuclear Medicine and Molecular Imaging and European Association of Nuclear Medicine. Greater integration of PET-CT in tumor boards and NCCN guidelines. At tumor boards, they expect to view and review full studies across multiple sites, whether specialists involved in the patient care are often spread out to discuss key images and findings, so a timely interventional and therapeutic plan can be developed. Here I'm showing an example of NCCN guidelines appropriate use criteria, where you can pick any form of cancer the patient might have in the proper clinical setting, and it'll give you guidance as to the imaging exams to use. And here I've picked a lymphoma, and also you can see where PET-CT is highlighted for imaging recommendations. Keeping in mind all that I have discussed so far, we cannot have fragmented solutions in nuclear medicine, which are neither efficient nor cost-effective for all involved in the field of nuclear medicine. For example, we shouldn't have to review general nuclear medicine on a legacy system or a vendor A platform, then review the same patient's PET-CT on a vendor B platform, and then do planning dosimetry on a separate program. I have seen sites where the number of screens can get up to 6 with several CPUs in use. And this is not to mention all the daily issues a nuclear medicine tech might encounter as well. As our field becomes more complex, we should streamline as many processes as possible for nuclear medicine physicians and technicians. The need is for a single integrated nuclear medicine imaging platform to process and display general nuclear medicine studies, display advanced PET-CT studies, have integrated cardiac software, whether it be general or PET-CT, within the platform, and not have to launch it separately and use dosimetry and therapeutic tools to personalize treatment plans for patients. Seamless integration with institutions' PACS and IT requirements. Since PACS is at the core of any radiology department, any new system coming in has to be compatible with and should not have high infrastructural requirements that will unduly inflate the costs. Vendor neutrality is key. What I mean is, regardless of the camera system one might have across sites of various ages and different manufacturers, an imaging solution that can process and display data across all of them without any issues or delays. Full access remotely is also important, especially in the current era. So my journey in this field started in 2010, a few years removed from my fellowship. I was in Montefiore Medical Center. The structure at that time was as follows. We had hospitals and outpatient setting. We had 3 camera vendors for general nuclear medicine and PET-CT, 3 imaging softwares, no systemic integration across sites, approximately 50 rotating residents while providing 24/7 nuclear medicine coverage. So it seemed very fragmented and not very efficient. So I reached out to my chairman and proposed, why not invest in a single imaging platform that is vendor neutral to create a fully integrated, customizable system to take advantage of all the efficiencies on multiple levels while reducing costs. And with my enthusiastic approval from my chairman, I went out with my search. And like anything in academia, I started with my research looking into different systems. And at the 2010 Society of Nuclear Medicine meeting, I was able to test and assess various systems that were available at that time. All had their positive points, some more than others. Hermes was the farthest ahead in regards to displaying and processing general nuclear medicine studies and displaying PET-CT. It was user-friendly and very intuitive to use, flexible and display templates, responsive to customer needs, considering all of our practices then and now are not 100% alike and have some unique requirements. A brief snapshot about Hermes, if you're not familiar with it. They've been in existence for about a half a century in molecular imaging software. They have a wide global customer base across multiple continents, covering more than 700 hospitals and in more than 47 countries. 100% focus on nuclear medicine software. They've had several firsts to the market. First commercial medical imaging fusion software, first commercial SPECT reconstruction software, and first FDA cleared dosimetry software. They provide a single workstation solution over a siloed processing on OEM workstations and modalities, one data management solution across multiple sites. As I mentioned, their focus is molecular imaging software with regular updates. They have dedicated molecular imaging tools for all clinical specialties. An example would be BRAS for neurology, uniform results and access to quantification. And since we're consolidating different systems into one system, there are significant advantages on the economic side. There's optimization of use of imaging modalities and move to precision medicine and value-based care, an example of which would be voxel-based dosimetry for patients to develop personalized treatment plans. Here's a standard architecture which can be completely customized to workflow of any small or large practice, whether it be major academic center or a small private practice. Cameras are connected to PACS and Hermes, primary and backup server. HL7, which can be used across satellite and clinic sites, and radiology information system is connected to the app server with the output of a reading workstation, whether it be on site or remote via the VPN. With Hermes, one can work across all of nuclear medicine, whether it be neurology, pulmonary, cardiology, musculoskeletal, gastrointestinal, and oncology, to name a few, in a single workstation, whether it be static, dynamic, or hybrid imaging. In addition, there are dosimetry and therapeutic tools to guide treatment. Even though at the end I will show several representative examples, I just wanted to start with one example at this time. Here we see the utility of Hermes, where functional PET brain images can easily be co-registered to CT or MRI, in this case MRI, for the corresponding anatomic imaging to combine optimal functional and anatomic data to guide diagnosis and treatment. So returning to my example when I was at Montefiore, this was our pre-Hermes workflow. We had multiple gamma cameras across 2 hospitals and an outpatient site, which were read on vendor stations, and images were stored on CDs with manual transfer of images, which was not optimal for several reasons. For example, if one is on call overnight at one hospital and a lung scan comes in, and if the prior positive lung scan happens to be the other hospital, then one cannot know if the defects they're seeing are new or old, which would have a significant clinical impact. And this would require either the tech from the other hospital to come in just to load those images, or one has to wait till the morning for somebody to manually push over the prior study. And all of us know CD storage is not ideal due to the possibility of loss or data corruption. PET-CT cameras, as noted, were solitary. They were not connected to any other site, and they had to be reviewed at the outpatient site. So if anybody from other sites wanted to review them, whether it be for clinical research purposes, they would have to go to the outpatient site where the PET-CTs were located and review them on the camera vendor stations. Especially when you're doing research, you have to wait till all the clinical work was done for the day before you would have access to these stations. We had a seamless integration in 2012 with our current PACS at that time and the hospital current systems. We had great customer support pre, during, and post installation. There were individualized, customized templates and hanging protocols. As we all know, any of the systems come with generic templates, but often we like our current templates and or would like to create templates that optimize our readings. Initially, the Hermes programmers stayed on site with me till all of these were created. An interesting example was one of our most senior physicians loved his reading board where one had rotating hard copy images of studies and was not so eager to let go of them. So for him, I created digital templates on how he liked to view the studies. And once he saw the utility and ease of use with Hermes, he was more than eager to let go of his reading board and the legacy vendor-specific stations after having used those for several decades. Remote access for resident support and remote reads. I'll get more into this on a later slide. They've also been responsive to our needs with the fast turnarounds for requests of need. Often, like if it's simple enough as in terms of templates, they will get back to us and have a new template created within the day, or sometimes like a couple of weeks for more complicated needs, as compared to the vendor where would put a customer need in and it would be several weeks before we would hear anything back, going back to R&D, and it would be several months before we would see a solution, if at all. Another thing I wanted to focus on was Hermes having floating licenses. And these licenses, as I mentioned, are floating and not fixed to any station. So they're portable across sites and can be used remotely, thus giving institutions, physicians, and technicians the freedom to work from anywhere to maximize efficiency while keeping the costs low. This is our post-Hermes workflow. All the gamma cameras and PET-CT and the PACS were connected and integrated with Hermes with the output of Hermes stations, whether it be workstations for processing on the tech side or thin clients for full review of studies with all the Hermes tools across all sites. With implementation, we eliminated the need for vendor-specific workstations, which are not cheap. In 2012, each of these workstations cost around $50,000 on the PET-CT side, and thus we only had 2 stations. So if multiple residents and attendings wanted to review studies, they couldn't simultaneously. Only 2 people could do that at a time. Obviously, the costs are likely lower now, but there's still a significant outlay. We're also no longer tied to any particular vendor stations when pursuing the latest and the best cameras for our institution, since now we had a vendor-neutral platform which worked across all vendors. It provided us with efficiencies at multiple levels. Here I'm showing some examples of efficiencies at the tech level, which provided them with greater automation, greater and robust tools that were previously unavailable on the proprietary camera vendor workstations, greater flexibility in processing. Many times hospitals are a multiple site department, means technologies are spread out across various sites, but having Hermes, they could work across any of the sites and process imaging data from the other area, providing a greater educational tool for the techs and greater flexibility for the institution. Greater consistency, ability to produce data that is comparable across multiple vendors, irrespective of what camera is used to acquire imaging data over the course of patients' visits. An example would be following a patient for renal differential function over time. There are also efficiencies at the physician level. As I mentioned earlier, you have customized templates and hanging protocols, allowing for faster reads without compromising quality, eliminating the need for physicians to travel from site to site, resulting in saving of time, which could be applied to various facets of the practice, whether it be reading more cases, resident education, research, or administrative time, which in my case included responsibilities related to being the program director for the nuclear medicine residence program, to name a few. Along the same lines, when Montefiore added a new hospital to the network, all the nuclear medicine studies there were able to be read remotely from our current sites via Hermes, even though they were using a different camera vendor, without any extra cost. Faster and easier training for rotating residents and visiting training physicians who came to us to learn and interpret PET CTs. Multidisciplinary and interdisciplinary learning in the form of tumor boards has become integral in patient care, where nuclear medicine, especially PET CT, is very much valued by all specialties to understand staging, restaging, and guide biopsies and therapies. Pre-Hermes, we used to make PowerPoint slides for all the cases for each tumor board, where there could be 10 to 12 cases. When this is multiplied by 8 to 10 tumor boards a week, one can see the significant time investment that was needed to do this beyond all of our other responsibilities. Now with Hermes, it can be launched from the desktop being used for the tumor board, and the full study with all the comparisons are available for review, which will result in significant time savings that were no longer needed for the PowerPoint presentation. Also, if any clinical service wanted to review additional findings on the scan, which previously might not have been on the static PowerPoint view, this could be easily done in a live environment. Obviously, being an academic center, resident education is key to our mission and goal. We had about 50 residents rotating between radiology and nuclear medicine. Rotations for radiology residents could be anywhere from 1 to 2 weeks, and for nuclear medicine residents, anywhere from 1 to 4 weeks. Residents were located at 2 hospitals and 1 outpatient site. Prior to Hermes, the training required them becoming familiar with multiple cameras and legacy software systems, which was often very tedious and not efficient. Since the rotation could be short, the retention rate was low. Often residents needed refreshers, which they returned when they returned for follow-up rotations. Limited to no connectivity across sites. On-call sites were difficult for the radiology residents, which were located on a different floor. So when there was a static imaging done, such as a VQ scan, the tech would have to print out hard copies of the images, take it to a different floor where the radiology resident was reviewing studies across all the sites, and they would have to put up in the old imaging board and review them, formulate an impression, and report the results. This was more complicated when they had to review dynamic studies, such as a GI bleed study. The residents would have to leave their workstation, go down 2 flights to the nuclear medicine department, review the study, formulate an impression, come back up while other studies were getting piled up, and then report the study out. Review with attending at that time was not possible for general nuclear medicine studies, since the attendings were remote and they did not have access to these studies. So if there was a study which needed attending input, they would physically have to come in on site at one of the hospitals. PostHermes was a single platform across all sites. Training was fast and efficient. High retention rate since it was used system-wide on a daily basis by all the residents. Studies were also optimized for single click. On-call studies became much more straightforward, where the Hermes Thin client was installed on the radiology resident workstation, so they can review both static and dynamic images at the workstation and manipulate the images as needed and report the study out. And if they wanted to review a study with an attending, the attending could easily log in remotely via VPN and review the study with the resident, contributing to resident education and optimizing patient care. And reviewing and viewing studies across sites became much more straightforward, and you can manually pull up the studies yourself without depending on anybody else if needed. There were several research tools in reconstruction, voxel dosimetry, nuclear medicine processing, and neurology toolkit, and all of that could be exported in the form of Excel file for data analysis, and images could be transported for purposes of publications. There was a significant improvement in turnaround times that looks at completion time of study to the attending sign-off. The left chart is the weekday turnaround time, which includes normal business hours and studies done on call. One can see pre-Hermes, the average turnaround time ranged from a little over 12 hours to a little over 16 hours. And post-Hermes, the average turnaround time ranged from around 5 hours to 6 hours, with more than a 50% drop in turnaround times. The effect on turnaround time was even more dramatic when looking at weekend turnaround time, where the turnaround time went from an average of between 60 to 70 hours to around 10 hours. Pre-Hermes, the residents would prelim these studies, and the attending would review the study on Monday morning, resulting in a significant lag in final sign-off. But post-Hermes, the attendings could review these studies remotely and sign off. This also helped in cases where teams in the emergency room or the floors would not discharge a patient without the final report, resulting in significant cost savings for the hospital. So in 2019, I moved to a multi-specialty private practice, which was at core oncology based, but they also had radiation oncology, primary care as well. They had 2 PET-CT cameras. The studies were acquired and sent out to outside radiology service for reads, with a turnaround time on average of about 3 to 5 days. There was less than optimal communication with the teleradiology service, and no tool for imaging review for the referring physician or review images simultaneously with the reading physician. So in 2019, the practice decided to start their own radiology department. And I was recruited to lead the nuclear medicine section and grow and expand it. After assessing their workflow and significant growth potential, to me, the only solution and the optimal solution was a single vendor-neutral imaging platform. My past experiences with Hermes guided this relationship here. And we had a seamless integration with Hermes in November 2019, showing that Hermes is very flexible, whether it be a large academic center or a private practice. Regardless, they're able to integrate with any and all systems. Since then, we've had significant expansion in sites and diagnostic and therapeutic services, going from 2 to 7 PET-CT cameras, which will very soon be 10, addition of several new imaging agents and a theranostics section. This was the pre-Hermes workflow, where the PET-CT images are acquired and stored on a CD, and as we discussed earlier, that's not optimal. It was sent out to the external PACS, and they were read on the proprietary software that the teleradiology service had. Post-Hermes, both the PET-CT and the PACS were connected to the Hermes server, and the output was in the form of Hermes thin clients, which could be used at multiple facilities or for remote reading as well. Being a private practice, we're very busy and it's a high throughput. And what we look for is like high reliability, high consistency, high quality, flexibility, and vendor neutrality. And Hermes is provided with all of these parameters at a high level. With fast growth and greater expansion comes greater complexity, significantly greater data movement, and requirement to integrate with several external systems of our partners. We import and export studies to and from outside institutions and teleradiology services. We even have studies migrating in from across the nation and the world for the patients receiving care with us. I am sure many in the audience have had the experience when a CD from an external site comes in for review, which might have its own set of unique labeling for series, and an imaging format that is not often compatible with the current imaging platform. So one has to review them on a desktop while trying to get acclimated to the imaging software on the CD, trying to figure out how to manipulate the images, make measurements, and compare to an in-house study, which are all less than ideal and very time consuming. The seamless uploads with external studies that Hermes provides due to its vendor neutrality, which is inherent within it, where it can work across all camera vendors. This applies not only to PET-CT, but to full spectrum of nuclear medicine studies and CT and MRI, where CT and MRI can easily be co-registered to optimize functional and anatomic data. I will briefly touch on pharma, where there's a significant research pipeline currently in the diagnostic and therapeutic fields in nuclear medicine. Studies are conducted nationally and internationally, where a vendor-neutral imaging platform would be invaluable since it provides high quality, consistency, and reproducibility. And since these studies are being and trials are being conducted across various settings, whether it be large academic centers to community-based hospitals to specialty cancer care centers and private practice, you need a single unifying imaging platform where you can have high quality, consistency, and reproducibility, which are the hallmarks of a well-designed trial. So at this point, I will switch over and show some case examples via the Hermes system. So here's an example where you see it was a single click. I go to the app label of the lung view. The patient with a recent international travel and pleuritic chest pain. And the template, the way we like to design, we like the anterior and posterior views. We have like the perfusion on top and the vent on the bottom. This can be customized in any which way you personally prefer. And this one you can clearly see there's a defect in the right lung seen in multiple views compatible with the PE. The next example was once again single click. It's a patient coming in with bright blood per rectum for evaluation of a GI bleed. And you can see, obviously, very important to see dynamic images, but you might want to see frames also. So you can initiate the dynamic study, and you can start seeing some activity in the left abdomen, which moves in an anterograde and retrograde fashion, and a serpengus fashion as well, compatible with the small bowel bleed. And if you want to fine tune it by looking at each frame to see when the bleed started, you can do that as well. You can, if you save additional static images, you can scroll through them as needed, and the dynamic if you want a bigger screen to view as well. Next is an example of a HIDA scan, a patient presenting with right upper quadrant pain for evaluation of chronic cholecystitis in an outpatient setting. This is pre-CCK dynamic, post-CCK dynamic. This is the way we would like to display it. Once again, these are all fully customizable in any way which you like. This is the way we created the templates. Anybody can create them any way you want, and like Hermes guides in providing these templates. And I can see both of them, pre-CCK and post-CCK simultaneously. And you can see gallbladder visualization, activity entering the small bowel, and a post-CCK, you can see very good clearance. And once again, you can localize in the frames in terms of when the cardiac blood pool clearance is, when the time gallbladder and small bowel are visualized, and if any static images were done, if there were anterior obliques done, all of them would be here. And you can quickly go to the screenshot, you can see the analysis, and you can see the ejection fraction, about 99%. Here's the Cardi study, which is launched from within Hermes, whether it be a C to sinus or 4DM. Here's a patient with multiple comorbidities and dyspnea and exertion coming in for evaluation of myocardial ischemia. You can view the raw images. You can adjust the ROIs as needed. You can look at ejection fraction. In this case, is excellent. And the splash screen to look at images on the short axis, vertical long axis, and horizontal long axis, and the study being a normal study. Next is an example of a renal scan assessing for obstruction and function. Once again, you can actually cine the images, and you can see the renal activity, which provides with good clearance, with some activity localizing to the renal pelvis. Once again, you can look at individual frames to see when the activity in the kidneys were visualized initially. You can go to the screen captures, which shows the differential functions, T1 halves, and the curves, and the ROIs, which can be adjusted as needed on the fly. Next is an example of a bone scan. And if you've noticed so far, they're all single click studies to open the studies and immediately opening in the templates the way we like to see them. And these can be designed any which way you like. We like to see the planar images on one screen and the spec CT on the other screen. So there was activity in the right chest, and you wanted to make sure none of that is involved in the lower ribs. So when we come down to the spec CT images, you can clearly see the activity is more in the soft tissues, and you can correlate the findings on the low dose CT, where you can see the activity corresponds to site of post-surgical changes. You can actually, if you like a 3x3 view, you can build it in that way. So we had people at my sites who liked certain views, but they're all built into a single template. So all of us can use one template, but individualized differences can be accommodated. If you want to look at specs in different view, you can do that as well. I wanted to show one parathyroid example. Once again, the planar images will open on one screen, the spec CT on the other. This is a good example showing the value of doing a parathyroid scan, and also shows you how easily you can review all the findings on a single screen, where we see a lot of places will have early and delayed images, and some places might even have a delayed protective scan. And you can see the ectopic parathyroid adenoma. And you have additional views on the spec CT, so you can actually localize where it is, and you can actually make snapshots, which we did, and you should send it to the surgeons so they can see it on multiple different views to guide surgery. And once again, the specs in different views can be looked at. Now moving on to some PET CT examples. Many in the audience and many Hermes customers have been using PET CT for a long time. So I'll show them in the imaging platforms that are available for PET CT. The first is an example of a gallium PSMA 11. And once again, this is the way we like our PET CTs displayed. Some people like 3x3 views. I personally like this view, but completely individual choice. Here's an example of showing the primary disease in the prostate. But the reason I'm showing more is because these gallium patients obviously are on the scanner for a long time. So there tends to be a lot more motion, which you can see here. And this would require, if there happen to be on a pathologic side, whether it be like cervical nodes, or if you're trying to differentiate between if the lesion is in the brain or the calvarium, it's important to appropriately co-register images. So if I was to take this and just use the registration tool, you can see the arrows appear, and I can, on the fly, just quickly move it over and press OK. And you can see it's completely appropriately co-registered. And you can see the value of it, like if you had like pathology in the cervical nodal stations or the brain or the calvarium. Next, this is an example of a patient presenting for staging for breast cancer. So you can see the primary site, possible satellite disease in the left breast, and multiple nodes in the left axillary and subpectoral nodal stations, and some of them are very close to each other. So you can use a single segmentation tool to achieve the appropriate SCV values. You can see them, but you can see it's kind of forming lesions that are right next to each other. So if you want to split them, now you can just do a single click. I was able to separate the lesions out. And in addition, I'm able to actually see them individually by max, mean, or total lesional glycolysis. And if you right click here, I can even look at the metabolic tumor volume as well, whether it be for research studies or for radiation oncology and so forth. So it's a nice tool. You can easily separate out the lesions that might be very close to each other. Here's an example where a patient presented after having tumor markers elevated with a history of pancreatic cancer and status post Whipple procedure. So this patient had a PET CT and an MRI close to each other, and I will show you. So the PET CT identified a focus in the upper abdomen just right of midline. And if I was to zoom in on the low-dose CT, it's hard to make out what this lesion is. But since the patient had an MRI, I'm able to grab the appropriate sequence and just replace it on the CT side and automatically co-registers it. And you can see actually a lesion on the MRI clearly. And if I was to load another template from the same to where you actually see a better view of the studies. So you can see both the low-dose CT fused with it, MRI fused with it, and you can clearly see a lesion on the MRI as an ill-defined T2 mildly hyperintense enhancing soft tissue. So we're able to combine both anatomic detail of an MRI and the functional data of PET very seamlessly to clearly show where the recurrence is. An additional example is looking at lutetium images across multiple time points. It's lutetium SPECT across 4 time points. So I'll just focus on one lesion, this particular one right here. And I will mark it across multiple time points. And one can see you can graphically display data regarding SUVs automatically, whether it be mean, if you want to look at the max SUVs, or lesional glycolysis. So very easily you can display data across multiple time points and assess how the patient is doing. So at this point, I would like to thank all the audience members for giving us their time to go over the possibilities that exist for efficiency gains using single imaging platform. And if you have any questions, feel free to reach out to the email addresses provided on the screen, and we'll be more than happy to answer any and all questions. Thank you.